So we already have a lot of people here. I think we should just get started. And I was trying to figure out if anybody was called in. So if you're called in, can you say something? We can't really tell if you're called in or not. So I'll work on that while the speakers are speaking. But I do know we are connected to Zoom. So in the future, if you're coming to one of these or you want to come and you can't quite make it, we are videotaping them and we're live streaming them. So you don't get the food, but you can join us in any one of those ways. So I'm Anita Moon-Grady. Most of you know me. I'm one of the pediatric cardiologists here. Thank you for coming to our monthly Heart Center Research Symposium. I think this is, every time is better attended. We're going to have to look for a bigger room pretty soon. The purpose of this Heart Center recurring symposium monthly every first Wednesday is mostly to let us all know what's going on right under our noses in the Pediatric Heart Center, but also to foster collaboration across campuses with the Gladstone, the CVRI, the Oakland campus. And so it's being supported right now in whole by the Department of, by the Division of Cardiology. Phil Moore, if you're listening, thank you for providing the food, and to Penn Collins, who's our clinical research coordinator, who does most of the work in getting this organized. Before we introduce our speakers, I wanted to go over some additional resources as part of the Pediatric Heart Center research efforts. We have a website. If you don't have the website address and can't remember phc.ucsf.edu/research, you can email Penn, which is what I did. Can you please send me the link again? And you do have to log in, which is what I wanted to show you. This is not a public-facing site yet, but if you log in using your same MyAccess credentials, you'll hit our landing page. So this is Pediatric Heart Center research page. From this page, you can look at what we are doing currently, a whole host of research projects from clinical research to basic science, and encompassing also the cross-collaboration with the CVRI and the Gladstone. It has a list that will have a calendar function as soon as we get it working, but if you want to see which seminars are coming up right now, you can look. Here's Patrick and Chad. And you can get more information on those people. This is also this site if you are a person anywhere within the Pediatric Heart Center. We do have small amounts of funding from the research collaborative to fund small purchases of things that you may need or statistical help, and so you can apply for that. Either if you have a big grant, you can submit an application. There's a call for applications now, due June 1st, for larger grants, or if you have smaller needs, the links to requests. These are all electronic requests. If you want to request a research assistant or clinical research coordinator time, please go to this webpage. So one-stop shopping for news, upcoming research highlights, lectures, and funding opportunities, all on this page. So I encourage you to use it. It's as easy as I just showed you. You just click on the link, log into your MyAccess, and you're on the page. So explore, it's live, and we welcome any feedback that you might have. So with that, I'm going to ask people again, if you're called in, please mute your line. If you have a question, we'll take questions at the end. Are there any people called in from the Gladstone or from the CVRI? CVRI, anybody? Gladstone? They either aren't hearing me or they're not telling. How about Oakland? Is the Oakland connection working? Okay, if you can't hear me and you're called in, I'm going to step out after this, and I'll make sure that you're able to see us, so don't panic. I want to thank Patrick McQuillen and Shabnam Peyvandi for agreeing to give the next lecture in our lecture series. Most of you know them. Patrick McQuillen is a professor of pediatrics and is a critical care specialist and has really been at the forefront of this topic, neurodevelopment and congenital heart disease, for several years. And Shab Peyvandi within the Department of Pediatrics, Division of Pediatric Cardiology, is also gaining quite a lot of national attention for her work on this topic. So I will, I think Shab is talking first. Patrick is talking first. They're going to split the hour. The title of their presentation, again, Neurodevelopment in Congenital Heart Disease, Brain Imaging and Optimizing Outcomes. Patrick.
Thanks, Anita. Thanks to everybody who's come for lunch. This is a fun talk to give. When Shab said, hey, let's give a talk, I thought it'd be nice to do a little dog and pony show. And going first, I get to be the dog. I also get to really just give the history and the overview of this project. And Shab's actually going to present a bunch of very exciting, very new data in contrast to what I'm going to tell you about, which really extends back about over 10 years now. But what I'm going to try to do in the beginning of the talk is just give you a sense of the research program that she and I both work on together, trying to understand brain development and risks for brain injury and implications for brain injury in newborns with critical congenital heart disease. And I'm going to, particularly, I'm going to try to set up a clinical problem that we identified and published with early results that upset a lot of people and left us kind of hanging with what do we do with this information. And so the theme of the talk today really, neurodevelopment in congenital heart disease and neuroimaging, but really, optimization of outcomes. I think what's nice is that published actually just today on the Journal of American College of Cardiology is a paper that Shab wrote with some very exciting new data that's come from following these kids into childhood and continuing to assess their neurodevelopment that really provides what I find to be a very satisfying and nice sort of way to interpret some of our early data and helps us know what to do with it. So let me just take a step back and put congenital heart disease into the context of other forms of brain injury or conditions that are associated with brain injury in newborns. And so when people think about high-risk problems around birth, being born premature or having a difficult birth and term birth asphyxia often come to mind. But congenital heart disease is not only very prevalent, it is the most common birth defect. And the numbers per year rival that of babies exposed to birth asphyxia, such that the number of kids that are affected by developmental disability or death, and these are sort of ranges from published data of the rates of those two problems, are really pretty significant. So it's a big problem. Now, so many children who are born with what we call critical congenital heart disease, and we define that as needing surgery within the first month of life. Many of these kids, luckily, because of improvements in surgical technique and life support as well as intensive care, they're surviving. A lot more kids are surviving, and they're growing up, and they have a range of impairments that luckily are actually not so severe. So these are not children that are born with serious developmental delay and cerebral palsy. These are kids that you'll see on the playgrounds at school, integrated into the regular grade appropriate level, but they have a lot of problems. And so when you start to test them, they really deviate from what a normal control population should look like. So this just gives you a flavor. This is actually one-year outcome data, and Shab later in the talk is going to tell you that one-year outcome data is actually completely useless for congenital heart disease. But this is what our kids look like when we test them on a simple test called the Bailey Scales of Infant Development. It has two components, a PDI and an MDI, and like all IQ-type tests, it's standardized and should center around a population mean of 100, okay, with a standard deviation of 15 in either direction. So the normal population should have a bell-shaped curve extending out to here. What you can see is that the children in our study, and this is actually from 6 or 7 years ago or so, they're significantly shifted towards the right. And it also has this unique pattern that we tend to see, and part of the reason why the Bailey at 1 year is not so useful is that it seems that the PDI or the motor component of this Bailey test seems to be more affected at 1 year than the MDI. Oops, wrong computer. Okay, so let me contrast that story and talk just a little bit about advances in congenital heart disease. And I've included a figure here from Tara Karamlu's paper looking at these really actually stunning progress that we've made in congenital heart disease. So this is just looking at outcomes for the Norwood procedure. And there are two categories here. I want you to basically just ignore the dark black bars and focus on the dark gray bars. And look at these eras that we've all actually lived through. From the early 90s to the mid-2000s, mortality here for the Norwood procedure dropped from nearly 90% to really, in contemporary estimates, somewhere around 10%. I mean, so we've had remarkable improvements in a decade or maybe 2 decades in getting these kids to survive. And yet in the same era, when we look at how their neurodevelopmental outcome have improved, we haven't seen nearly as sharp an improvement in neurodevelopmental outcomes. So the kids are surviving, but they still have these residual impairments. And this is data that we contributed to. This was actually a neat study that Bill Gaynor did, where he basically asked anyone who had published any neurodevelopmental testing in congenital heart disease to pull all the data. So there's problems with this data because it comes from 2 different eras. The early era is mostly transpositions. The late era are mostly infants in the ISV trials from the PHN. But once you sort of control for all of that, what you get is an improvement in the MDI and the PDI, the same pattern I showed you before where the PDIs are worse, of maybe 2 or 3 points per year. So really not stunning progress in terms of neurodevelopmental outcome. Okay, so we were interested in this issue, and so approximately I think 12 years ago, a colleague of mine, Steve Miller, who's a child neurologist, we got together with a little bit of internal seed money, like the magnitude of the money that Anita was talking about on these grants that the Division of Pediatric Cardiology is making available. And we studied 10 patients with transposition of the great arteries and wrote a paper with that, and then started a cohort that has persisted and has had continuous funding for over a decade now. Stephen went back to first British Columbia and then now to Toronto, and we've continued to enroll patients together, and our total sample size now is up to about 234 patients that we've imaged. And this is the structure of the study now. It started really with just preoperative and postoperative neuroimaging, and we collect a lot of clinical data, as well as data up in the intensive care unit like cerebral NIRS. And then we follow the kids for neurodevelopmental testing between 1 year and 8 years. We have a sample that's heavily represented by babies with transposition of the great arteries, which was the initial entry criteria, and then also infants with hypoplastic left heart syndrome and variants of single ventricle physiology. So that makes up, nearly 80% of the cohort. Now, part of the reason I wanted to show you that picture is because of the 2 people seen here pushing this machine that Duan Zhu and colleagues actually made. But just sort of to inspire some of the fellows and junior faculty in the audience, when you get these seed grants, you don't actually get study coordinators assigned to you or anyone else who helps you with the research. You actually go and do it, and you push the babies down to the scanner and monitor them and take them back. Now, let me just give you a flavor for what the sort of original focus of the study was and what we learned. So let me take a step back and say that at the time, this was actually an incredibly brave thing for our colleagues within the Heart Center to actually participate in. When I went initially to Frank Hanley and Mohan Reddy, and then to Tom Carl and said, look, I want to enroll every newborn that you're going to operate on and do a brain MRI before surgery and after surgery. I'm sure the first thing that they thought is you're going to pin a brain injury that occurs on cardiopulmonary bypass on me, because their brain are going to look normal, and then they're going to have an injury afterwards, and someone is going to sue me. So I think this took a lot of courage to actually do it. And the very first surprising finding that we had, now this is a very complicated table, I want you to just focus down here. This is a table that's going to summarize, it's going to compare two studies, one the Hearts and Minds study, which is a comparable size study done in Australia and New Zealand, along with our study. And this data is actually a little bit out of date, but the percentages are there. But here I've just summarized any injury, and the most surprising thing that we found to start with was fully a third of the babies have injuries that we never suspect on the preoperative scan. So as soon as we identified this, then this study became the darling of the surgeons, because it clearly shined the spotlight away from what they were doing in the operating room. And we then went on, so they do pick up. Another third of babies show up with injury on the postoperative scan. And we started analyzing this data for clinical risk factors. We wanted to learn, like, how can we do better? Why are these injuries occurring? What are the risk factors? And probably the first 10 papers that we wrote were all looking at the association of clinical risk factors with the various forms of injury. Now, there have been a couple of other centers who've done similar studies and with similar results, minor differences. But somewhere around a third of the babies get injured preoperatively, a third of the babies get injured postoperatively. But fully, and I tell families that enroll in this study, you can expect to hear from me that I'm going to tell you that your baby has some abnormality on MRI. Because fully, almost 70% of babies have some abnormality. And so now you can pay attention to the rest of the categories here. And these are the kinds of injuries that we see. And I'm going to show you examples of all of them. They fall into sort of three big bins. White matter injury, which I've divided up into mild and moderate, and Shab will tell you later why that's important. Stroke, and then intraventricular hemorrhage. And so you can see overwhelmingly the injury is in the form of white matter injury, about 40%, and then about a third of our babies are having strokes. So let me show you what these injuries look like. This is our crude grading scheme. We've actually come up with a much better way of measuring the burden of white matter injury. But what you're looking at here are coronal sections, so through the front of the brain. It's a T1 weighted sequence, so water is dark. And in the newborn brain, sort of the gray matter is lighter than the white matter. So you can see the strip of gray matter, and you see the darker white matter underlying it. And so the first thing and this was really a surprise because this form of brain injury is very common in premature babies and was thought at the time when we did these studies to never occur in term babies. But what we started seeing were all these very small, most of them less than 2 millimeters, punctate lesions within the white matter. And so Stephen, my colleague, had already come up with a crude grading scheme for when he sees these injuries in preterm babies. And so we grade them as minimal if there's less than 3 spots, moderate if there's more than 3 spots, or if any one spot is kind of big, if it's more than 2 millimeters. And then severe, this is sort of a semi-quantitative, really qualitative grading when Jim Barkovich tells me that more than 5% of the white matter is affected. The Australian group uses more than 10 punctate lesions. So that's how we grade white matter injury. Here are the strokes that we see. Now, when I tell families that your baby had a stroke, they usually, yes?
You could do I think, I mean, it's too late, it may be too late now for these, but I think you should do that on every one of these kids, because I don't know what you're gonna find, but it wouldn't surprise me that you're gonna find mutations or genetic alterations in a large percentage of these kids. It's gonna be relevant.
Wholeheartedly agree with you, and thanks for making the point. And we've never been funded in our study to do it, but we are, and this is part of the reason why Anita was asking whether any of our colleagues from the Gladstone are here, but we're actually participating in a study called the Brain and Genes, the Heart and Genes, what the hell is it called? But in any case,
Unbiased whole exome. I had my exome sequence.
yep. So this is in this study they're collecting and sequencing, doing whole exome sequencing in at I think about 8 centers across the country, and we're bringing the babies back for then neuroimaging. So we're trying to do exactly the same, exactly what you're suggesting. So let me get back to get through here what these strokes are. These are not the strokes that your grandfather gets when it's a devastating total middle cerebral artery stroke and leading to hemiparesis and aphasia. These are really small strokes. So now, as opposed to the last scans, what you're looking at are 2 pairs of scans, one a preoperative, one a postoperative scan. Now it's axial, so it's cut through the brain at this section. T2 weighted image on the left, and barring the arrows, the actual stroke site is kind of hard to see. So on the right is the easier sequence to see this. This is the diffusion weighted imaging and the ADC map. And here you see an area of restricted water diffusion, this dark area that coincides with that loss of gray-white differentiation. This is a small focal embolic stroke in a preoperative transposition. This is a very unusual location, slightly larger in the posterior cerebral artery location in a baby with hypoplastic left heart lesion. So, and these are actually, of the strokes that we see, these are among the larger ones. Sometimes the strokes that we see are really very, very small, maybe a centimeter or so. So when we started to analyze, well, actually, hang on a second, I'm ahead. There were 2 big themes to the early papers that we wrote. One of the themes were risk factors for injury, and I'm going to come back to that in a second. The other big theme was this idea that brain development itself, separate from acquired brain injury, that brain development itself may be abnormal in newborns with congenital heart disease. And so my colleague Steve Miller wrote this paper that appeared in the New England Journal of Medicine, and we used 2 techniques, magnetic resonance spectroscopy as well as diffusion tensor imaging. Those are all both a little bit complicated and hard to explain. But what we basically found was that the brains of babies with congenital heart disease, and it didn't matter the type, whether you had hypoplastic left heart syndrome or transposition of the great arteries, they appeared about a month, 4 to 6 weeks delayed. So they appeared similar to maybe a 34 to 36 week premature baby. And subsequent to this, at least 4 or 5 other groups have found the identical finding using different approaches. And so I'm going to show you an example of a technique called morphometry, where we can take these high-resolution thin-cut scans and actually, rather than looking at all of the brain, we can start to segment out the gray and the white matter. And that's shown here with these overlying color-coded images. And so we can segment here in red the cortical gray from blue, the white matter underlying it, and then in light blue, the deep gray thalamus and basal ganglia. And since they're 3-dimensional image series, we can actually then reconstruct any one of these segmented lesions. And so what I'm showing here is that we've reconstructed now the interface between the white matter and the gray matter. And so that's shown here. The cortical gray, or the whole brain, is reconstructed here, and the deep gray is reconstructed here. But if you take a look at that interface between the gray matter and the white matter, you can look at how the gyri and the sulci, so how the shape of the brain actually develops over time. And so what's plotted onto these 3-dimensional reconstructions of the white matter, gray matter interface is a measure of convexity, so how curved any particular region is, and it's color-coded so that the most convex regions are red and the most concave regions are blue. And so you can just pay attention to the emergence of red and blue, and look in this series of both fetuses and then preterm babies up to term, that the brain goes from being very, very smooth to being really bumpy, okay? And then you can compare here a term baby at 40 weeks with hypoplastic left heart syndrome, and just look for the amount of dark red and compare it here to the term baby and compare it here to the 34-week baby. What you can see is that this baby with hypoplastic left heart syndrome, the brain is comparably much smoother than you would expect at term, really about a month or so delayed. So delayed development was one big story, but the other big stories were the association of clinical risk factors, and that's where I want to just bring up this conundrum that we identified. And then I'll also just allude to what Shab is going to talk about in the rest of the talk. Hopefully she's going to demonstrate for you what the true utility is of neonatal neuroimaging. And actually, I was very pleased because Shab's paper that appears today on the JACC website has an accompanying editorial, the title of which says, is it now time for neonatal neuroimaging as standard of care? We've thought that it's been time for a long time, but now people are starting to agree with us. And we're going to give you a practical example. So what I'm going to move on to talk about is an association of a clinical procedure, a balloon atrial septostomy with stroke. And then Shab's going to talk a little bit more about the significance of the other major type of brain injury, which is white matter injury. And she's going to give you an update on the neurodevelopmental assessment in the population, and then we'll finish with talking more broadly about what can we do with this data to optimize outcomes. So the second paper that we wrote in this study appeared in circulation with this title, Balloon Atrial Septostomy is Associated with Preoperative Stroke in Neonates with Transposition of the Great Arteries. And so this is an interesting lesson in sort of clinical observations and sample size. So if you peer here into the abstract, you see we looked only at 29 term newborns. I mean, it's got to be the smallest sample size for a study published in circulation ever, right? 12 of these babies had brain injury, either white matter injury or stroke, and that's really important. Remember that it's, for this paper, we lumped it together. All of the babies that had brain injury had balloon atrial septostomy, okay? So this, this was when you have a sample size of, 12 out of 12 that had the procedure had an injury, you got to A, be worried, but B, also be worried that it's a statistical quirk. But this really upset a lot of people. They were thinking, oh my God, there's this strong relationship between a catheter-based procedure and stroke, but these kids will die sometimes if we don't do the procedure. So babies that are born with transposition, and if they have inadequate mixing, they're very cyanotic, and they can be hemodynamically unstable. And so the balloon atrial septostomy is to widen a communication between the atria and allow for mixing and bring up the saturations. And so this is important because we also identified some other risk factors within this population. So as expected, on the basis of the need for the balloon atrial septostomy, these neonates, the ones who had the brain injury, also had lower systemic arterial saturation. Okay, and that's important because other groups have not seen such a tight observation or association between stroke and septostomy, and really what they've focused on is this hypoxemia, and then actually how long the babies are exposed to hypoxemia, so time to surgery. So this was the first paper that we reported, and there were lots of editorials about it and lots of people talking about it. One of the things we were worried about is that it was, with a small sample size, it was going to influence the rate at which we do the procedure. And so, and as I've alluded to, there were other things that might be important. There were two types of injury, and there's also hypoxemia. So we've continued to analyze this association through every paper that we've published. And the first thing was I was worried that Phil and his colleagues were going to stop doing septostomy so frequently, and luckily that hasn't happened. So the rate of septostomy across our publications, as our sample size has gone from 29 to 152, hasn't changed. But this association, so first of all, when I say injury here, this is for white matter injury and stroke together, But the rate of stroke, initially we were estimating it at about half of the babies, and in a larger sample size, that was probably an overestimate. But still, about a third of these kids have stroke, okay? The rest of the brain injuries that you see are in the form of white matter injury. So that leaves you with again, this conundrum, like, what do I do? This baby's gonna die unless I do a balloon atrial septostomy. But if I do a balloon atrial septostomy, a third of them are gonna get a stroke. So, who should we be doing the procedure in? And I'm going to turn things over to Shab now, and I think you'll find that the answer is actually quite simple.
So actually, what I think I'm going to do is skip forward a couple slides to here. So we're both very excited to share this data with you. This is, as Patrick mentioned, just recently published data looking at, in particular, neonatal brain injury and timing of neurodevelopmental assessment in these patients with critical congenital heart disease. And this really looks at all of these patients that have been followed over this 12-year period and reporting their neurodevelopmental outcomes at both 12 and 30 months of age. So you can see here for this particular study, we looked at 165 patients that did not have genetic abnormalities. As Patrick mentioned, we now have about 240 subjects in the cohort overall. And at 12 months, we had 104 subjects that had follow-up, some with transposition of the great arteries, others with single ventricle physiology. And the prevalence of brain injury was similar to what's been reported in the literature, as well as for white matter injury. And then at 30 months, we had another 70 subjects that had continued follow-up. So we did have some loss to follow-up due to various reasons, as well as some patients that died prior to coming back for their follow-up exams. And at that time point as well, you can see the prevalence of brain injury in those subjects that had 30-month follow-up was similar to what's reported in the literature. So at both of these time points, these patients had, which Patrick has already alluded to, the Bayley Scale of Infant Development second edition, which gives you a psychomotor development index score, the PDI. It's an assessment of motor skills of the baby. And it also gives you a mental development index score, which is the MDI, and it's sort of a cognitive assessment of the baby. And at both of these sites, this was done at 2 centers here and University of British Columbia. These tests were administered by a licensed psychologist blinded to neuroimaging and the clinical status of the baby. So what I'll first say is that the interesting part was that we found no association between neonatal brain injury and outcome at 12 months of age. And that was in contrast to what we saw at 30 months of age or at 2.5 years of age. And I think the main findings from this paper can really be described with this one figure. So in this figure, where's the, oh, here it is. This figure, what we're looking at is the difference in the psychomotor development index score, comparing patients with different types of brain injury to the reference category, which in this case was patients with minimal to no brain injury noted on their perioperative MRI. So what we can see is that both patients with transposition of the great arteries and single ventricle physiology, I see in this red line here, with moderate to severe white matter injury had significantly lower PDI scores at 2.5 years as compared to those with none or minimal injury. And they were statistically significant. And that was still significant after adjusting for biologically significant variables like maternal education, the site, as well as whether or not the baby had had a balloon atrial septostomy. But in contrast to that, if you look at the top part of this figure here, when we compared the patients with stroke to our reference category, you can see, particularly in transposition, that these patients actually had almost better PDI scores as compared to the reference category. And even on the univariate analysis, some of these observations were actually statistically significant. So this really demonstrated to us that these small strokes that Patrick just described actually do not translate into worse neurodevelopmental outcomes, and it's not as bad as we thought. In contrast, moderate to severe white matter injury seems to be related to poor neurodevelopmental outcome, particularly poor motor outcomes at 2.5 years of age. So if we look at this data in a different way, some people ask, well, what were their actual scores on these tests? As Patrick mentioned, the mean PDI in the general population is around 100 with a standard deviation of 15. So if you look at patients with none or minimal injury, their PDI scores were pretty close to the general population, around 92, so not a huge difference from what we would expect. But patients with moderate to severe white matter injury had a significant drop in their PDI scores, which is less than 1 standard deviation below the general population. So that's a significant decrease from where these children should be and suggests significant motor impairments, at least at 2.5 years of age. And so the findings from this paper to us suggest that neonatal brain MRI is useful in critical congenital heart disease. It demonstrated to us that small strokes that we see often in these patients, particularly transposition, are not associated with poor outcomes. However, moderate to severe white matter injury is associated with worse motor outcomes at 30 months of age. And the other interesting point to make about this study is that it has implications for future clinical trials in our area of research. As we move towards an era of looking at agents that can be considered neuroprotective and designing clinical trials, we're often faced with this conundrum of an intervention that may occur in the fetal or neonatal period and that long time period until the primary outcome is assessed at 2.5 years of age or even later in childhood. But these results suggest that perioperative brain imaging can potentially act as a surrogate outcome variable, since we did find this association with outcome later in infancy. The other interesting opportunity we had with this study, since we did have neurodevelopmental assessments at 2 time points, at 12 and 30 months, and the fact that we found no association between neonatal brain injury and outcomes at 12 months of age, but we found that association at 30 months, it made us wonder why we saw this difference. And we were able to look at the differences in scores at these 2 time points and understand what was going on. So this is a Bland-Altman plot, and what's on the x-axis here, this is the mean PDI when looking at the PDI at 12 months and 30 months. And the y-axis is the difference in the PDI score between those 2 time points. So if there was perfect agreement in the PDI score at those 2 time points, you'd expect most of these dots to be along this 0 line here. But in fact, you're seeing this wide scatter of all these data points, which suggests there's wide variability between these PDI scores at the 2 different time points. The limits of agreement ranged from -40 to about 30, which is a huge range of variability, and demonstrates to us that there's really no agreement between what we're seeing at 12 months and what we're seeing at 30 months in these patients. In other words, what an infant looks like at 12 months tells us nothing about what they're going to look like at 30 months, and most likely nothing what they're going to look like in childhood or adolescence. And this data has been explored in other patient populations, like in premature babies, and has been noted, but it's sort of the first time we've demonstrated this in the cardiac population. So this data tells us that continued neurodevelopmental follow-up is important for patients with congenital heart disease. And I think particularly because, as Patrick mentioned, these kids are actually in mainstream school. They tend to do okay, but they have a very unique developmental profile that is pretty specific to the cardiac population. And some have termed this the neurodevelopmental signature of complex congenital heart disease, where they may have normal IQs on cognitive exams, so they don't have global cognitive delays, but still struggle with academic achievement, with social interactions, with executive functions, which I've learned a lot about thanks to our neuropsychologists that are in the audience, which has to do with memory, organization, planning, and all of those issues lead to difficulty in performing everyday tasks. And some of these, as you can imagine, these issues wouldn't be picked up necessarily in infancy, and that speaks to the importance of continuing to see these children in childhood and beyond. And in fact, in 2012, the American Heart Association released a statement recommending developmental evaluations in these children. They identified a set of high-risk babies with congenital heart disease, those that require open heart surgery, children with cyanotic heart lesions like tetralogy of Fallot, and any combination of congenital heart disease and comorbidities like prematurity, genetic abnormalities, or requiring cardiopulmonary resuscitation. And for this high-risk population, the recommendations are that they have serial developmental evaluations at the minimum once in infancy at 12 to 24 months, once before going to school at 3 to 5 years of age, and a third time prior to sort of adolescence is another milestone at 11 to 12 years of age. And I think despite the fact that these recommendations were released in 2012, many heart centers across the country are a little bit behind the time in ensuring that these children are getting these baseline evaluations. We here at UCSF have been very lucky with support from the Pediatric Heart Center as well as from philanthropy. We've been able to create the Healthy Hearts and Minds program, which is a cardiac neurodevelopmental follow-up program. We work in collaboration with our colleagues in neonatology with the Infant High-Risk Follow-Up Program. And the importance of this is that their developmental evaluations don't end in infancy, but actually go beyond that time in childhood and adolescence. We were able to bring Stephanie Cox on board, which is in the audience and in the picture here, and she is providing these detailed neuropsychological evaluations to children and adolescents with critical congenital heart disease. So I encourage people who follow these patients on the outpatient setting, for if you have patients that are considered high risk, to talk to us about it and consider sending your patients to be seen, given the fact that their developmental issues can be quite subtle and not noticeable to parents and their physicians. Okay, so with that, many people ask us, okay, you've observed these changes on MRI, you know they have these neurodevelopmental issues, what can we do to optimize outcomes in these patients? And as Patrick alluded to, there have been several studies that have identified risk factors for poor neurodevelopmental outcome or brain injury on MRI. And this is a slide that he created that demonstrates those risk factors, some of which are not modifiable. So if you have a genetic syndrome, we can't really modify that. If you have single ventricle physiology as opposed to other types of congenital heart disease, we can't really modify that. But you can also see that there are things such as length of time to surgery. Some single center, smaller studies have suggested the earlier you go to surgery in the neonatal time period, the better the patient's going to do from a neurodevelopmental standpoint. That needs to be replicated in bigger studies, but has been suggested. But in general, the other thing we can see from this table is that perioperative hemodynamic stability seems to be a risk factor for poor neurodevelopmental outcome or brain injury on MRI. So as a fetal cardiologist, I knew that prenatal detection of congenital heart disease, although it doesn't improve mortality in these patients, does lead to neonates with better preoperative hemodynamic stability, just because we know about their heart lesion already. So we asked the question using this data, does prenatal detection of congenital heart disease make a difference with regard to brain injury and brain development? We had a good number of patients with both prenatal and postnatal diagnosis in this cohort, and we found that our hypothesis was true. Prenatally diagnosed patients had evidence of less brain injury compared to those with postnatal diagnosis of congenital heart disease. And in fact, they had less severe brain injury. So, and this is seen in panel B here. These are the brain injury severity scores that Patrick talked about. Prenatally diagnosed patients had less severe brain injury compared to the postnatally diagnosed patients. And additionally, we found that the prenatally diagnosed patients had a faster rate of postnatal brain development. This is looking at fractional anisotropy in the white matter, which is a measure of microstructural brain development. And I won't go into too many details about this, but just to say that as development increases, the fractional anisotropy goes up. So you can see that with this orange line here, these are the prenatally diagnosed patients, had a faster rate of increase in their fractional anisotropy from the pre to postoperative MRI as compared to the postnatally diagnosed patients, and that was statistically significant. So this data is really compelling because it suggests that just by prenatally identifying congenital heart disease, we might be improving their neurodevelopmental outcomes down the line. So we found this data very exciting to just support the importance of prenatal detection of congenital heart disease. So with that, we're almost running out of time. So we thought we would just talk very briefly about what we're currently doing and what we hope to do in the future. And that really has to do with an interest of mine, and which is fetal markers of neurodevelopment and congenital heart disease. Just as many of you in the audience are familiar with this, but we know that the heart development is largely complete by the end of the first trimester. And this is in contrast to brain development, which extends throughout pregnancy with morphologic events occurring in the first 2 trimesters and growth and refinement of connections happening in the 3rd trimester and after birth. So that 3rd trimester of in utero life is marked by accelerated brain growth, organization of the cerebral cortex, increased metabolism, and an increased demand for oxygen. And the heart responds to that, as we've learned from Dr. Rudolph's studies, that there's an increased blood flow to the brain in the 3rd trimester, such that 25% of the cardiac output is directed towards the brain. So this demonstrates that this heart-brain relationship really begins in utero. And we think that that in utero relationship is what somewhat, and to some degree, influences neurodevelopmental abnormalities in this population, brain injury, and abnormal brain development. And so what we're embarking on, which is very exciting that we're doing this, we are looking at advanced fetal imaging modalities with our colleagues in neurology and radiology to help us understand this relationship a little bit better, particularly MRI. And then also utilizing maternal hyperoxia as a tool to help us temporarily change physiology in the fetus so that we can understand cardiovascular and cerebral hemodynamics. So hopefully if we're invited back in the future, we can go over some of our preliminary data. So in summary, I think some of the themes that we've talked about during this talk really go to show our efforts in trying to improve neurodevelopmental outcomes in this population. We've demonstrated that neonatal neuroimaging, particularly brain MRI, is useful and it's predictive of outcome. Small strokes are not bad, but moderate to severe white matter injury leads to worse motor outcomes. And I think this is particularly important because this suggests if we see moderate to severe white matter injury as a neonate, that baby should really be referred to regional center, make sure they're getting their developmental assessments, and begin early intervention as soon as possible to make sure they have the best possible outcome. We've also demonstrated that continued neurodevelopmental follow-up beyond infancy is warranted in this patient population. Again, the earlier you catch some of these deficits, the earlier you can intervene upon them with therapies and hopefully improve their outcomes. We've shown that prenatal diagnosis is neuroprotective, and we're hoping in the future that by combining advanced fetal neuro and cardiac imaging that will improve our understanding of the heart-brain interplay in utero. Some areas that we're hoping to work towards in the near future, we've alluded to this a little bit during the talk. We're interested in looking at timing of surgery for critical congenital heart disease, early versus late. Does it impact your neurodevelopmental outcome? And given our expertise at this institution, we have an opportunity to study the premature infant with congenital heart disease, understand their burden of brain injury and their ultimate neurodevelopmental outcomes. And I think our interests don't really end in the research realm, but can actually extend into what we do clinically for these patients. As I know some of our colleagues are giving this a lot of thought, such as Martina, really pooling our strengths in neurology, in critical care, and in neonatology, and thinking of clinical programs such as a neonatal cardiac intensive care unit with a focus on neurologic care to make sure that these patients are receiving the care that they need from the get-go and hopefully optimizing outcomes in the long run. So with that, we have a long list of people that we need to thank. For me in particular, most of the work that I've done really couldn't be possible without Patrick's mentorship, as well as collaboration with these individuals in neurology and radiology and neonatology, as well as our research team that we've listed here. And I'd like to give a special thank you to the families that have supported our Healthy Hearts and Minds program, some of which are here in the audience today. Without them, we could not have established this program. So thank you. questions if anyone has questions.
Shab, that was really excellent. I have a question on the most recent JAMA paper. It looked like, if I got the numbers right, that you lost a follow-up about 60 out of 160 patients. Do you know if those patients had an equal amount of brain injury on the initial scans, or do you think that there was any, like maybe the healthier kids didn't come back, that would skew your results on the ones you followed?
No, that's a good question. So I didn't show that data. I didn't show that data, but we did look at the prevalence of brain injury in patients who had follow-up versus those that didn't, and it was equal. There was no difference. And so your point is well taken. Is it only the healthier patients that sort of showed up? But even if that were the case, we still found that association. So that just suggests that even if those sicker patients made it, we probably would have found a stronger association, we assume. Any other questions? Yes.
So, my son had surgery 23 years ago, so this was not on the radar. So, as a practical matter now, with newly diagnosed babies, is everyone consistently talking about this with families, or how does it work now?
That's a very good question. So one aspect of it is that we are diagnosing these patients more often prenatally. And there's been a lot of discussion about whether or not you should discuss neurodevelopmental outcomes in the prenatal when you diagnose this prenatally. And I would say that for the most part, most fetal cardiologists mention that there is a risk of neurodevelopmental impairments, but the degree to which that impairment exists, we don't know and we can't predict. But even, I would say, most of my colleagues mention that, but there's been papers looking at counseling patterns prenatally, and there's a lot of variability where some practitioners actually don't even mention it. And this was a paper that was published about 2 years ago. So I would say, yes, we're definitely moving towards this being mentioned more often, but I think we still have some more work to do.
So you showed that 1 year didn't really pick up in your developmental since about 30 months. Is there any way, and this is thinking of intervention, is there any way you could pick earlier, and does it really make a difference if they get intervention between 1 year and 30 months? Would that change their outcome?
Possibly. Yeah, if they got some sort of early intervention between 12 and 30 months, I would think so. For like a neuroprotective trial.
Yeah, so do you think there's a role for like earlier screening to try and pick them up before 30 months, or should we just wait?
Oh, I see. You should, yeah, exactly. I think yeah, exactly. I think that now that we're showing this association between brain MRI and outcome at 2.5 years of age, at 30 months, the MRI is really going to be a useful tool. Because if you see that injury, moderate to severe white matter injury, you should get those patients plugged into early intervention.
Shannon, Stephanie, do you guys want to comment on the utility?
100%. I think we would say yes, they should all be in intervention, just given what's happened from a developmental perspective, as you just discussed, in terms of the brain and the heart developing potentially together while this is going on. Things are not going as they should. So all of those kids, we would recommend that. But I think if there's something like a brain MRI it allows, then their treating physician to say, yes, this is what you need to do immediately.
Would insurance cover?
So for all of these kids under 3, the regional center, their local regional center, should cover PT and OT regardless.
Speech and language and ongoing
And
monitoring.
speech and language
Yeah,
ongoing
I have
monitoring.
to, I think early intervention, they're really hemmed in by what they're allowed to cover. And if a patient who's referred to them doesn't show a 66% disability in one area or 33% disability in 2 areas, they're not going to get services. That's the shame of, having very little
But I think there's a lot of education that's starting to happen in regional centers, and so things like MRIs show
Exactly,
the
yeah.
outcomes of what this means later on, and so
It's not going to get coverage though.
unfortunately, we have systems set up right now that react to problems that exist once they exist, instead of proactively think about what is this going to mean in the long term.
Yeah.
And so there is a little bit of a paradigm shift that has to happen, I would say, and certainly so for patients who don't have insurance, I think there are workarounds in terms of how you can try to ensure that they have access to those services if they don't have medical insurance and can easily get PT and OT and things like
And the other, what I've heard also, just to go towards the potential usefulness of neonatal brain MRI, is that if you do have an abnormal brain MRI with injury, that actually makes more of a case for them to have services through the regional center, because you have something documented that's abnormal in the medical record. So that's another reason why MRI may actually be useful for this patient population in the neonatal time period.
That means white matter.
Yeah, so the question was, does that mean, what, I'm just repeating the questions for the people online. The question was, does that, yeah, does that mean white matter injury? I would say, because we want these children to get these resources no matter what, I think if there's any injury on MRI, that's going to be used to their advantage, and they're going to be plugged into these services. Yes.
I have an odd question. In your paper, you have two groups of TGA and single ventricle. As what I understand that they better oxygenated, the blood did not come to the brain as in normal physiology of the fetus. Do you have any comparison with other congenital heart disease where the blood, oxygenated blood is near normal physiology? Is this different?
Oh.
Like the
The question was, do we have any comparison between the patients that we've looked at with single ventricle physiology and HLHS that we think have impaired oxygen delivery to the brain versus patients that are normal? Is that correct? Like a control subject?
Because I think the doctors who knows this is not brain to the because the physiology is switched, so the better oxygenated, the blood is not drained to the brain as normal. So in two groups, it's maybe there's some difference.
Yeah, so this has been a fascinating question for us to think about. Every time that we compare just TGA to single ventricle physiology, we don't see differences among the group. I think it may be a sample size issue and just the power of the effect size. So the answer, your specific answer, we haven't looked at enough babies that have the physiology that you're talking about. What we have done, though, is within the single ventricle physiology patients, if the hypothesis is that it's brain oxygen delivery, within the spectrum of hypoplastic left heart syndrome, from aortic atresia to aortic stenosis, you get a range of impairment of brain blood oxygen delivery. And so in a paper that Sarah is on, who helped us with this, we saw a significant association between anatomical characteristics, so either presence or absence of aortic atresia, or the diameter of the ascending aorta. The babies with a predicted physiology of more impaired blood flow looked more immature. So that's I think, been the closest thing to proving that hypothesis.
So we have one question from one of the callers. Actually, it's for you, Patrick. Do you think that the change in prevalence of stroke after BAS, I assume at UCSF, was due primarily to the sample size, or the larger sample size, or did our catheterizers change the protocol in some way?
You have to ask, I think Phil slipped out. David did.
We have the only thing we changed is we decreased the frequency that we do it. We base it on saturation.
Yeah, and let me if I haven't been heavy-handed enough about this, so Steve will kill me if I keep saying stroke's not bad, because stroke is clearly bad. And in Shab's paper, we show there were two babies that had more than small strokes, and those babies have PDIs that were 2 standard deviations below. So large strokes are clearly bad. Small strokes, probably if they're in a bad area, are bad. But what happens is that, as we all know, the procedure, we do it for a reason. And so presumably the improvement in oxygenation and brain oxygen delivery is preventing white matter injury, and that's why the outcomes look better. We don't have the sample to really convincingly show that, but that's the general idea. But so the answer to the caller's question is no. I actually think we just again, it's like one of these things where at some point early in your career, you're going to do a clinical study, and you're either going to get really lucky or really unlucky with an inappropriate small sample size, and just we way overestimated this association. And so I think that the real prevalence is probably about 1/3 of the babies get some small embolic stroke.
defect is less than 3 millimeters, it gets a balloon. Have they shown any difference in incidence of stroke, or have they even studied that?
The
Yeah,
paper
so
that
the-
came out after years.
Yeah, the problem is that other centers, other big imaging groups have not seen this prevalence of stroke. And so in particular in CHOP, they say they never see it, but in other papers, they definitely report strokes. And that just kind of gets into the nuances. There are things that we call stroke that they wouldn't call stroke. So if we see a diffusion positive lesion in the white matter and it's diffusion positive, particularly if it's much bigger than what we'd expect for normal white matter injury, we call it a white matter stroke. They would call it white matter injury. So I think we're all seeing the same things. But the other thing is there's subtle differences in the study design. We do our preoperative brain MRIs when the babies are clinically stable, which is usually a day or two after they get their septostomy and not on the day of surgery. And so our imaging is probably closer to these strokes. And so the diffusion positivity is only going to be 5 to 7 days, maybe even less for the smaller strokes. So it's possible that when you do it on day of surgery, you may miss some of the small strokes.
Are we out of time, or do you have one?
We're kind of out of
Okay.
time. I think we should probably
All right.
call it a day.
Thank you, everyone, for coming.